Well, everyone, I want to welcome everyone to the Ask the Expert session here. To introduce myself, my name is Dr. Joe Sirven. I am an adult epilepsy neurologist at Mayo Clinic in Arizona. And joining me is another colleague from Mayo Clinic in Arizona, Dr. Matt Hirth.
Yep. So I guess we represent Mayo Clinic here, but we're here to kind of answer whatever questions you may have. Our Mayo Clinic is kind of a network across the country, so we're from Arizona, but we also have sites in Florida as well as up in Rochester, Minnesota. So so we're happy to answer questions, open this up to the floor. I'm not sure what else you need to.
Right, I think that the main thing is, like, today the session was on hard to manage epilepsy. We don't have a formal presentation. I rather thought that what I can easily start by saying is that we are at a time when there are a lot of options. There's not a perfect option, but there can be perfect options for some people, as we've had from our members of our audience. There are multiple operations for some people. There are devices. There's at least 3 approved devices for epilepsy. We have somewhere close to 28 different medications that are on the formulary at some place for the management of epilepsy. And even the good old-fashioned ketogenic diet that's been around, taken up for other purposes, for weight loss, but actually was an epilepsy-derived aspect of treatment as well. And now, one of the other things that's around as well, there's a lot of now devices that are wearables, seizure learning elements that now exist as well that are all available. So having said that, that's the preamble to say that we have a lot of different options. So where do we go? Right now, what we're trying to do in the science of how we manage is with 28 drugs, with a number of operations, with 3 devices, tons of wearables, how do we, when someone sees you in the exam room, how do you match the right treatment, right approach to the person in front of you? We don't have a great answer in terms of how to direct people that way, but that is the goal. That's the ultimate goal, is to identify people to individualize treatment. This is a big deal, and to pull it out back, this is a very big deal in the worlds of cancer treatment, where you try to match cancer treatments, and there's a lot of different ones available for them, to the individual patient with that individual tumor type, and there's all these extra tests that they do. Well, epilepsy's in that early zone. There's a lot of tests, and we're trying to match that treatment to the patient. And that is where we're trying to get to, but we're not there yet. So we thought what we do is, as you heard from Dr. Hirth, is to answer what we can. We can't be your private physician for the session, but we can speak in generalities and try to give at least general sense of where different things are used. We're also very aware of we're very involved in governmental aspects of things when it comes to transportation, driving, flying. So we know that game as well. So we are here to, I guess that's our big preamble to say, give us your best shot and we'll try to help you out with whatever question we have. So we'll just do it by if any comments or questions that you may have at this beginning to start us off.
The only other thing I guess I would add is, a lot of people can, we can get them seizure-free, but there's this whole other aspect of, well, what about the treatments? What are the treatments doing to you? What are the side effects? Those sorts of things. So those things are important. How is it affecting your life, right? And so, we try to, that's the other individualized piece that we can talk about here too. It's not always about being free of seizures, which is very important, probably number 1 on the list, but it's like, what are those treatments doing to you? So feel free to, answer those questions as well.
So anyone want to start us off? Yes.
Yeah.
So we're not quite where you are. It sounds great. So we have a daughter. She's 16 years old. About 8, 9 years old, she started with the absence seizures. They went away for their remission for 3 years. She was on camera. And then she went back in to have an EEG to see if she could come off the medication. And literally the day after, she ended up having a tonic-clonic seizure after the EEG, after being seizure-free for 3 years. Fast forward about 3 more years, she is pretty much maxing out on the Depakote and the Keppra. And now that she's 16, she's on like 7 different meds. And now they have referred her to another medical group, I guess, out of her neurologist, going over to another group. And now, so we're right in that transition stage. To think about, we've got the history, we've seen this, we're learning, this is our first epilepsy day. Thank you everyone for putting this on. And so now as we transition over to a new neurologist and new system, what should we be thinking about? How do we think about that? So what it feels like is the current medications are not working. So then are we starting to should we evaluate new medication? What's our role? How do we talk to the new doctor coming in and make sure that, not to dismiss everything that's been done to lead up to this point, but how do we keep figuring out how to build on it? And what should we advocate for? What would she not care about? How do we not get distracted from moving it forward?
I'll start it off. So she's 16 and with all these seizures. So what I would be looking at the first step is that this is now almost a natural transition point or close to a transition point from pediatric neurologist to adult neurologist. That's the first step. And there is actually a fully fleshed out guideline policy on what should be included in transitions from pediatric neurologist to adult neurologist. Pediatric neurologists are really good about this because they know that they're going to have to transfer these patients, and that is part of their training. Adult neurologists may not be as good about it, but what they need to know is, in general, what medications have been tried, what the diagnosis is, the seizure rescue plans that exist in terms of what should be done in certain situations, school, work, things of that sort. This is also the time, if they have not connected, given the complexity of what you just presented, that they should be connected into some form of a formalized epilepsy center. Not that they're always the easiest to get to because there aren't enough of them, but nevertheless, those are where you're going to have your best shot to kind of get to the access for certain things. Let me also give you a little hope here. Like at the end, when someone has seizures at that point at age 16, that does not portend necessarily that's what it's going to look like at age 26, 36, or 46. There are some periods of where there's improvement or remission. The key is what is it in terms of diagnosis and sorting it through.
Yeah. And so the other concept, as you talk about transitions, right, that from that adult to pediatric, but this transition from kind of the general neurology care to the advanced neurology care. And we talk about this term, which sounds a little bit scary, but intractable epilepsy,
Yes.
right? And that's kind of what you're referring to, where, medications just don't seem to be working. And it's really at that point that we, as epilepsy specialists are suggesting to the, general neurologist. I mean, a lot of really good general neurologists out there. But after they've failed several medications, that's when we generally recommend that they kind of, offer that up to the higher level centers. Right. Again, there's not enough of those, but that's generally what we would recommend, because then they start thinking about other options, or maybe medications that aren't used as frequently as some of the other ones. And you just have to, again, tailor that care, specifically. But, that's a, difficult transition as they become young adults. That kind of story we hear quite often, where there were some seizures, they were kind of controlled, and then it's kind of that puberty hits, or whatever it is about transitioning into adulthood, that sometimes things come back, but that doesn't necessarily predict the future, right? So it might need a different answer than it was when she was gym.
When you say the formalized epilepsy centers, that would be like most of the exhibitors here, like in the schools?
Take a look at like where there's listed is a website, the National Association of Epilepsy Centers, and the NAEC has all the registered epilepsy centers in the United States. They may have others that aren't registered, but
Right.
they are one of the repositories of people who actually consider themselves as part of of the team, if you will, that's going to kind of that's going to care for that.
To be a certified center, there's like a checklist that they have to get
Correct.
marked off and certified. Not to say that there's other centers that just didn't go through that process.
Right.
But the NAEC is a good.
And they have a whole map and who's located.
And you may have already been referred to one of those places. It's quite possible. So
Did you transition at 16 or 18?
Typically, you transition it at the 18, but some people do start seeing adult epilepsy folks by age 16. It depends on who's accepting and what they consider on a comfort level from that standpoint.
And when we talk about transitions care, it's really, the if you talk to our social workers and those sorts of things, it's really not a date or an age, right? It's a process that kind of goes through, and we're working that on our adult side to be able to try to make that transition smoother. But it's it's usually the pediatric piece that they're kind of trying to move those things through. Talk a lot about how do we get patients engaged in their own decision making, right? Instead of sitting there and having the parents do a lot of the talking, it's okay. Well, we know we hope you're gonna go off to college or live on your own or do all these other things. Those are the things that we should be kind of starting to talk about at that transitions age. So, adulting. It's not very easy, right?
Right. I like the verb. Adulting is the right
It's a
one.
thing, right?
Sorry, just to stand up for one slightly of a tangent on that. As she's transitioning, general high level, she's a great student, but high level, do you tend to keep their hope up and treat them normal kids like you would keep them on a normal path? Or do you start getting them to consider, that there might be limitations and maybe you're not gonna?
I think we're both on the optimistic side. I'm
Right.
thinking.
Yeah, and it's like, why can't you do both, right? So there's a lot of people who have a lot of different needs for every reason. Seizures being one of them. One of the tough parts with seizures is that you don't have this outward all the time, like outward appearance of something is, bothering you, right? Or you have those things. So we do have a lot of high school, college age students. Yes, they may get good grades. They have the capacity to do that, but maybe they need a little bit of extra help. Like
Right.
maybe they need some accommodations, extra time on tests, or if, the big, massive test center is not conducive to them, maybe they, do things on their own or different things. They can do well in life, but it's just a few little tweaks. And a lot of adults need those things too, right? And so, it doesn't have to be one or the other, right? It can be both.
We try to do as much as we can to the person that they can.
Yeah, well, if you want some encouragement, I have epilepsy and I went through college and I have a master's.
That's beautiful. That's a great
Yes,
response
absolutely.
right
We
there.
have plenty of countless stories about, engineers and
Exactly.
all sorts
All
of
walks
different-
of life.
all walks of life. That's great. Congratulations. It's wonderful.
Yes, ma'am.
So is this the right lecture on hard to treat epilepsy?
Yes.
So when the regular medicines aren't working, never worked, and have bad side effects, what are the other ones that you said you might go on to? And what about mechanisms of action? Like, can you go a little bit into
Sure.
how things work? One of them I'm interested in is Oxteller XR. But I'd like to know what the other ones are that you're using that when the regular ones don't work.
I guess we can start off because that's a big answer.
What I'm kind of hearing maybe is how to pick your medicine, right? What is the right medicine to pick? Because we have 28 choices. There's going to be more. There seems to be one or two new ones every year, right? what is the right medicine for you, right? And we kind of have a list. We've published on these things, and we teach these things to our residents, and you know, how do we really choose a medicine? Because it gets very individual for a patient. I could tell you I think we all probably have a little bit of a different approach, but I'll just go down the list, so it's just for everybody. Number one, we have to make sure we have the right diagnosis, right? There's a lot of things that look like epilepsy, and I know this is probably not for this session or people here, but a lot of things that look like epilepsy that aren't epilepsy, right? And sometimes we even have patients with epilepsy, but then they have other events. Maybe they're passing out for different reasons, which we catch those sometimes too, where it's like, well, no, I shouldn't give you more epilepsy medicine because that's not your epilepsy that's causing the problem, right? The next thing is we got to pick the right medicine for the right type of epilepsy, right? So there's subtypes, you know, that we've heard kind of things like absence, there's focal seizures, there's different kinds of seizures, and we need to make sure that we pick the right kind of seizure. But then when we go to when you pick the right seizure, none of the medicines work better than the other ones, right? And so there's not one medicine. You mentioned Oxtellar XR, I've heard the words Keppra. There's no medicines that have been proven to be superior than another medicine based on their, you know, there's no data to say any of them is better. So then where do you go from there, right? So you start looking at all these other things. And it's kind of like, and tell me if this analogy is good, I feel like medicines kind of have their own personality. And with personalities, you kind of have to match the personality of that medicine, meaning like their side effect profile, you know, and kind of how, you know, that person is going to be with that particular patient or, you know, whoever we're treating. And so they kind of have to get along, right? So you mentioned Oxtellar XR as a medicine. So a lot of the ones with the XR at the end, that's an extended release sort of medicine. Well, you know, those can be good for patients who either don't necessarily take their medication at the same time every day or have trouble taking it twice a day, or maybe it's somebody who has, you know, kind of those dips in their day where maybe their seizures are happening right before their next dose, and that'll give them a little bit more of a cleaner, you know, blood level, you know, throughout the day. And so those are the kind of little details that we kind of look at to do that. So yeah, so you mentioned mechanism of action. I want Dr. Sirven's opinion on this too. Yeah, we look at those things. We know those things and we use those sometimes, but that's actually pretty low on the list. It's not necessarily the end of the list, but lower on the list of things that I take into account when I'm trying to help patients choose their medicine.
Right.
It does matter probably a little bit more when you're on multiple different medicines, because you want to try to have mechanism of action, and maybe I should explain that for
everybody.
the group. Mechanism of action, how does the medicine work? Like what receptor does it work on? So some work on like sodium channels, some work on GABA, some work on
Calcium
SV2AH, calcium channels. I mean, the list is pretty lengthy of the different ones, and we have kind of categories and different things that there. But if you're on multiple medications, sometimes a lot of people try to choose medications that are in two different categories to try to find a synergistic effect.
No, it's a beautiful answer for a very complicated question. But the bottom line is there's several different ways that a medication's going to work, and the diet and these devices, and the idea, even though it's not proven, but the idea is that if you mix different approaches together, that you may get a benefit. But a lot of people don't look at it that way because we don't exactly know how each of these medicines work. The general approach is we start a drug. We then give it a try. You try to get it to a maximum dose that they can tolerate, they can live with. If drug 1 doesn't work, you go to drug number 2. You do that and you try to see if that'll work by itself. And you'll give it as much as you can at the highest dose that they can tolerate or live with. And then at the end of drug 2, if you are still having seizures, you've fallen under the category of what we call drug-resistant or refractory or hard-to-treat epilepsy, as this talk is. At that point, the guideline says, well, number one, it's either you have a very difficult to manage case of epilepsy, that's why we prove the diagnosis, people get into video monitoring units or admitted for it at that point, or alternatively, and assuming that that's the diagnosis, then we say, we need to figure out, are you the focal epilepsy or you generalized? Focal meaning there's a distinct scar in a certain area of the brain, or is it generalized, there's more than one area? And if it's focal, then we look to see if you're a surgical candidate. Can we do epilepsy surgery at that point? Is there something we could do to finish this up and be done with this thing? If you're not, we can't find it, or it's generalized, then it puts us into the category of another med, third or fourth med, or a device. And the devices now, there's a vagus nerve stimulator on the neck, there's a responsive neurostimulator driven to a target in the brain, or there's deep brain stimulation that is also within the brain itself. There are probably, in Europe, not all approved here, there are now wearable extended versions of some of these devices that you can wear that give you this kind of a low-level stimulation. Not all approved here. They're actually approved in headache, not in the world of epilepsy. If those don't work, then you start looking for, the other, there's 28 drugs. You try to figure out what are the triggers? What are the things you can do in your own life to adjust for things? What are the environmental things I can do? Those things that you have to worry about environmentally. Not everyone is like this, but what you can do is, number one, in most epilepsies, we know lack of sleep is a problem. So sleep, you try to manage to make sure that you take care of sleep. We spent a bit of time. I wish I could do that, but it is that story. We spent a little time talking to some folks who are popping up by the Mayo site, talking about alcohol. You try to avoid alcohol because some people that is a trigger. In a third group, there's, and I'm going to go now very gender specific. In some women, not a big group, but a small group of women, the menstrual cycle is actually a big trigger for this. So in that case, what's done in that regard is to try to manage around the cycle to see what we can do from that standpoint. But that gives you kind of, I hope, maybe I have it in my head, but I wish I had it better here, a kind of a visual prioritization or way the algorithm flows to try to see how we can kind of get you there. The ketogenic diet is approachable at any moment, and that can be done for any type of epilepsy. But the problem with a ketogenic diet, and for those like me, is that you have to really you have to switch off carbs as much as you can. Not completely, because you can do it with a modified Atkins diet, but you have to kind of be able to follow that diet relatively stringently to get to a place where you develop ketones in your body to kind of get it to work. So you can see there's a lot of these different possibilities. It's just matching you up to what's the diagnosis, what's the cause. There's the other mix in this is that there are now, especially in kids, not in adults, we're trying to learn it, genetic testing that's done that sometimes can give us a sense of you have a certain type of epilepsy. Can that give us information on how to pick the right treatment for you too?
We're kind of on the verge of that genetics influencing treatment. Right now it's more to help a lot more with the why question, like why the epilepsy. I think we're going to see in the next few years this impacting on, you have this sort of genetic change. Maybe this medicine will work better for you. And that's kind of the dream where right now when we're talking about medicines, mostly medicines, not so much the other treatments, it's a lot about, okay, we think this is going to do well for you. We don't know, and we try it. And if that doesn't work, then we try something else. There's no other way of knowing if it works until we try it, right? So there's no good predictability there. So I think that's what frustrates a lot of my patients the most.
But my question was, what
It's about
are
next
the
time.
actual medicines that you would use when the regular ones have failed?
The problem with that the question, although I get where you're coming from, isn't as simple that there's this class and that class. It's really switching out what's worked or what's not. It isn't like it's like group 1 versus group 2.
Yeah, it's
That's why
very
I say,
individual. Yeah.
Let's talk about Felbitol.
okay,
Yeah.
I mean, I was hoping you guys would mention it, because I think most doctors don't want to use it.
I think Felbitol is a great drug. Okay, for those who did not come, who are not aware, Felbitol was the first of the new version of drugs, and new is defined circa 1992, which now it would be considered old. But nevertheless, Felbitol was the first of a new generation of medications. Came in 1992. The problem with it, and it was actually a temporary problem, but it was a mega problem, was that there was a defect in the manufacturing of the drug where it was being made. The problem with that defect is that it hurt people. And some people died, some people had liver failure, some people had all these horrible things happen. Notice what was interesting about that whole thing is that, yes, those cases happened, it was horrific. But once they identified the impurity, it just hasn't happened, but everyone was now frightened to death, and it's all over the internet, and that's what occurred. Having said that, the drug never got withdrawn by the FDA. And that is really the key, because if it did, then we know this is like ridiculously dangerous, that it couldn't even be on the formulary. But everyone's been frightened of it. The drug is useful for almost every seizure type, so it's broad spectrum. It's used in Lennox-Gastaut. It does have, the reason that people get nervous is that it does have drug interactions with almost most medications that are out there. So you have to adjust and check liver level, liver function, liver enzymes, and you have to check levels to make sure it's safe for that person, that they're not having side effects. And you have to check their blood count to make sure it's not affecting their bone marrow or anything like that. But most people, it's been okay. We use it fairly consistently, but it is general spectrum. It's nice in terms of the ability to think. You do lose weight on it, so that's something we also have to watch in some people.
Muscle or just
Weight. It causes appetite suppression. When the drug was going to come out in 1992, the hope of the company, had this not happened, was this was going to be the next weight loss drug for America. But it didn't work out that way. So that was the end of the story. But the weight loss was one of the biggest issues. But now everyone's very scared to use it. We tend to use it as a second-line drug, to be fair for what I was saying, meaning that I want to make sure I've tried other things first, because I have to check levels. It's still dosed 3 times a day, which is hard for people to remember to take. And you have to kind of be very mindful of that. But do we use it? Absolutely. It's still a decent drug for some people, but if we can find a medication that you don't have to check the drugs, it's fewer than 3 doses a day, and that people aren't frightened after they looked up the internet because of all the stories, we tend to go there.
well, we're here because the other drugs haven't worked. So
Right.
it's
Well,
about
Felbitol is fine.
alternatives.
Yeah.
Okay.
Yeah,
That
no,
they
it's a
seeded
good
over this way. Great
Yeah.
question.
So my daughter does have genetic duplication that we found when they first were able to have the technology to do it.
Yeah.
And there's one report in the world on her genetic duplication, and there is actually now one report on epilepsy related to her duplication.
Yep.
She has ESCS. It's part of it is ESCS.
Okay.
All of the women in the one study, 6 women in the world, their ESCS went away when menstruation started. My daughter's did not. So it's been like 5 or 6 years. We cannot get rid of the ESCS. Is there anything coming down the pipe on ESCS?
So I guess let's make sure that everybody knows what ESCS means. So
We'll
it's
get there.
electrographic status epilepticus in sleep, correct? Like I want to make sure that
Right.
we're talking the same thing.
Right.
No, I know. So it's easier to say ESCS, but you're meaning like when somebody goes to sleep, their EEG looks
Just
like they're having
constant.
seizures constantly, right? So,
She's tired.
Yes, tired, right? Because the brain just doesn't have a lot of time to rest.
There is, at this moment, is there something that I can say specifically? Not necessarily. We know that there's a couple of new approaches to, and I'm going to speak in generalities, that is not necessarily, that is towards ESCS, but more about different style. Number one, there are in trials elements of one of the medications, fenfluramine, which is in the world of antihistamines, actually, of all things, that was, it had a good result in Europe. It got approved in Europe. It's held up here because one of the trials wasn't so great, but it has been for very difficult to manage epilepsies, may have another approach, and we're waiting to see what happens with that agent, but it is one of the possibilities that's coming down the line. There are immune-based treatments that was never been trialed out in epilepsy, that the idea of using of some of the medications that they actually use in the world of multiple sclerosis is now in trials to see if you can, if there's, especially when seizures are that constant, is there some funny inflammation that can be quelled or calmed down? And those are in trials. Whether they'll be successful, I don't know, but that is one of those areas.
That's different from IV. She did an IVIG.
Yeah, this is different from IV. It's in the, it's what we call in the AB world because it ends with the AB.
Yeah. So monoclonal antibody.
Because that is one of the hot areas of most neurosciences. They come up with these interesting antibodies that may help to quell some whatever inflammatory process. And that's one of the areas. So I would say those, if I had to pick just generalities, are where maybe some of the hopes, especially in something that's that constant. And the other thing is that the idea is to apply this from an electrical, finding a stimulation device that might be able to, kind of like they do in heart situations where you zap things out, maybe something that will unzap it from an electrical viewpoint as opposed to medication. So
Stop that store, yeah.
that's the idea.
And that would be one of the devices.
It'll be one of, but there's also several now in trials. But the answer is one of the, I would say in a situation like that, I would be looking more in like something like deep brain stimulation or vagus nerve stimulation or versions, something where you don't have to target it, so to speak.
Unless it's well targeted, in which we don't know what the EEG looks like. So,
Yeah, that's why I wondered when you said that.
She's not a candidate for either one of those.
Right.
But that's why I keep wondering right there.
What you said about inflammation, does that mean that everybody who has seizures has inflammation?
So that's a very good,
That's a great question.
Interesting question, right? And so there is this kind of, it seems like a pervasive concept in all of medicine, where if we look close enough, the inflammatory pathways are involved in some ways. And so there's been several trials that have come up in epilepsy where we are looking at anti-inflammatory sort of medications, whether it's like specifically what's called monoclonal antibodies, it's attacking very specific parts of the immune system or different targets, or just general anti-inflammatory things. There's a cascade of different processes that happen when inflammation happens to try to stop the inflammatory process. And for whatever reason, we don't have any one that has come out of trials as of yet. There's been several that have been very close to being beneficial. But we do have these concepts, and this is an uncommon cause of difficult to treat epilepsies, but actually the immune system is the reason why seizures are occurring in the first place.
Really?
It's not common, and I say this as kind of one of, Mayo Clinic has kind of led the way on a lot of this concept, but it is a growing concept of when we've looked at kind of large trials of people who have intractable or medically resistant epilepsy, maybe, I don't want to put too many numbers out there, a low percentage, but still a significant percentage of people, we find these antibodies that may be attacking the brain or the nervous system. We got to find the right patients, and we've got to, look at it in the right way. And we haven't even discovered all of these antibodies yet. But sometimes we do use things like you mentioned IVIG and other immune system immune treatments to take care of patients. And sometimes it's successful, but it has to be the right patient in the right context to do this. There was a book and later made into a Netflix movie, this patient, Brain on Fire. I don't know if you remember this. That was
That's
kind of a form of one of these things. I'm not trying to advertise it, and it's very uncommon, but those are the kinds of things that sometimes you got to look at if medication, regular seizure medicines aren't working.
Right. That's fair. Yes, ma'am.
Yes, I was wondering if you could comment a little more on catamenial
Sure.
seizures
Oh,
and how to
good question.
Sure. So catamenial seizures are those in women who seem to have seizures in association with their menstrual cycle. And the general thought on that is that there is, in some women, there's a predisposition. They're more likely to have seizures at the time of their cycle because of how the cycle interacts with firing of neurons in the brain. The general belief is that it's related to the time when progesterone, there's two female hormones, progesterone and estrogen, when progesterone is lower and the estrogen is higher. And that tends to be about ovulation is when that occurs, and then
Just right before the menstrual cycle.
and that's when some women have to kind of notice that there's an increase in seizures when there's that mismatch on what's going on between the relationship between the estrogen and progesterone, that its estrogen is high and progesterone is low. There was a large study that was done, funded by the NIH on this topic. And what they found, it wasn't all women, but it was a small group, about 30%, that they could manage that in some women with the use of progesterone as a seizure treatment on its own. The problem with using hormones like progesterone with seizure treatment is that they're not innocent. Completely. There are risks towards uterine cancer when you take progesterone and things of that sort. And so it has to be balanced. And that's why this is one of those moments where the neurologist and the gynecologist or the endocrinologist have to be all on the same page. And it wasn't all the progesterone. It had to be a human-based natural progesterone. Something called prometrium was the one that was useful. While estrogen can be problematic in that regard. So when women are taking certain oral contraceptive, either for contraceptive or for hormone management for whatever purpose, the idea is if you can do the progesterone base, that is going to be useful in that situation. And that's what they kind of found.
So to just make this clear, though, which I think you did, but crystal clear, we don't believe it's the hormones that are the cause of the epilepsy, right? It's an influence on the
brain.
Underlying disorder, the brain itself. Because I know there have been some recommendations which we don't generally agree with, where people have gone and have had the ovaries taken out. or those
No,
sorts
we're
of
not
things.
saying that.
And that generally does not. It's not beneficial. And we do kind of talk about. We've seen some patients who now all of a sudden. We hadn't recommended, but it's happened, and now all of a sudden their seizures are not predictable anymore, and they're a different type. So these things are not always, very straightforward. But I want to be, I guess, clear on that point where, yes, there can be a very strong influence in women, in some women, on the hormones, but it's not the entire story typically, right?
what other treatments?
The other strategy is actually managing at the if the woman or a woman has seizures that is very well timed, sometimes it's all about just being timing the dose of extra medication at the time that they're most sensitive. So sometimes what we do is we use extra medication or a slightly different medication at the time of ovulation or right before the menstrual cycle if they're pretty predictable about it, because that is a way of giving you like that extra coverage without having to take it every day of the month at an extra dose. And so that has been kind of one of the strategies that you can use as opposed to specific med. If anything, what we use is something called a benzo, which is the Valium, the lorazepam, the diazepam, that can be utilized at the time of the cycle or at ovulation, just to bridge it, if you will, while they're most vulnerable, and then back it down.
Trying to kind of outsmart it. That's that tailoring and individualizing it to those women, because there's several different patterns that some women have. It's not a one size fits all, right?
Right.
And so different women have it at different times of their cycle potentially.
Okay. We'll go this way, then we'll go that, and then we'll go behind it right there.
We've had medication failure for seizure control, and you've mentioned 3 devices. I'm aware of the vagal nerve stimulator. Are there other types of devices, or is it just 3 different brands?
There's 3 different styles of devices. So the first device is the vagus nerve stimulator. Came out in 1997. It is basically a device that's placed typically around the shoulder, clavicle, right over
Kind of where a
here.
pacemaker would be placed.
And they wrap a wire around the vagus nerve, typically on the left, and it basically sends up a signal up that nerve every 1 minute, every 3 minutes, every 5 minutes, whatever we set it at a certain surge. And what happens is something about that seems to kind of zap things, to quiet things down a little bit. So we don't need to know the type of epilepsy. You just need to know you have epilepsy. It could be generalized, it could be focal. We tend to view it as a very good implanted medication as opposed to cure or anything along those lines. It can improve mood, even improve memory, but it is not. It varies by person to person. It's mostly you avoid the side effects of medications because they're not any of those medications, and you know they're on once they're programmed. That's the key. The second device, it is you feel it, but
Yeah.
it's hidden under the skin.
And there's different kind of sizes. They've tried to reduce the size of the device. So depending on which generation you got, or there's a few different ones of the vagus nerve stimulator.
Does it still interfere with people's ability to do some really hard exercise?
No.
Generally.
It used to, right?
No, right now, most people do a lot. We even implanted, I remember, on some folks that were even weightlifters, and they were benching things with it. We were horrified, but nevertheless, this is one of those. But people, you
do
can
a
get
lot of
away
things.
right there.
Yeah.
That's one thing that you can do. The second device that came out in 2009, 2010. That's responsive neurostimulation. That's implanted within the flaps, the bone itself of the skull, under the hairline, so that it is hidden. You don't feel it unless you're doing this. Yeah. But in that one, the electrodes are placed to go where the seizures are starting from in the brain. So you have to have decent targets to know where to put it for it to work. And it serves as both an EEG machine. It picks up the EEG cycle for the amount of 4 electrodes that's implanted in there, and it'll zap it when it does, kind of like a defibrillating pacemaker. And that's the second one that's out there.
Yeah, it's pretty advanced technology, and I'll say, if we found where the seizures are coming from, but perhaps can't take that piece of the brain out, to do a resection surgery, that seems to be beneficial. The better we know where it's coming from and pinpoint it, the better that one seems to work, right? In general, right? We can talk about the minutia of the data, but yeah. And that one comes with a very interesting piece, because we have to train it, or we have to tell it what to stimulate, right? So actually it records the data. Patients will have to download that data, and it goes to a secure server, and then we can see that data and use that data to tell it when to stimulate and change the stimulation. So
Right.
it's a very advanced piece of technology in terms of medical devices.
Right.
So it does take a little bit on the patient's part for that one. Rather than the VNS, you just kind of put it in
Right.
and
The third one is something called deep brain stimulation. It's been around for a very long time, actually in the world of tremor and Parkinson's disease, but got a recent approval for the world of epilepsy around 2015 or so. This is basically where they implant it to a very specific area of the brain. It is mainly, it's approved for what's called focal epilepsy, but is being looked at for generalized epilepsies, and that is relatively new.
It gets implanted in some deeper places in the brain where we think a lot of the seizure circuits go through, so we don't necessarily need to have a specific target for where that goes.
The last thing I will just say, as I want to kind of be, is that there's also, because I'm surprised someone hasn't asked me in the hard to treat, is like the CBD question. And I see all of that. So let me hit it before, because I see the door open. If I don't say it, how can I leave the session without that?
Yeah.
So CBD is more recently approved on a pharmaceutical grade version, which is the one that you see kind of listed there. CBD is approved, and here's the key. It is really only approved for 2 diagnoses because that's what insurance will cover. Otherwise, you pay out of pocket. It's only approved for Lennox-Gastaut syndrome and Dravet syndrome, and then very difficult to manage epilepsy depending on what your insurance company decides. I couldn't hear you. I'm sorry. Whoever. I didn't.
I heard somebody say something about a CBD.
Oh,
That's outside the room.
Okay. I was
So
like,
apparently somebody's gonna be talking about
wow.
Are you familiar with copaiba oil and frankincense oil being used for seizures? Because on the internet, and a friend of mine, I mean, it's all over the internet. A friend of mine, her daughter was having such bad seizures, she moved back home, and her mother put her on copaiba oil, and she hasn't had any more seizures. They put her in the hospital to see what kind of seizure she has. They couldn't make her have a seizure.
Yeah, I don't know. I have not, to be honest with you.
There's not a whole lot of large trials on that, so there's not a whole lot of data.
Have you heard of those oils?
Yes. Yeah.
Copaiba?
People actually bring up a lot of
Yep.
internet printouts to us.
Yeah, this is my friend who
No,
called me and said
but
it's working for her.
we have a whole repository of things that have in some people, and I don't know why it would in some cases. Even the CBD, we are not even sure why that necessarily works, because even that we're not certain that it works in the same way that we think it should. So I can't answer specifically to that, but yes, we have heard, but no trials to support in that. And so I always do.
Might help somebody.
There you go.
Yeah.
Fair enough.
Yeah. Absolutely.
I'm sorry. I saw this, and then we'll go that way.
Super quick. Just in the field of menopause and perimenopause, have you seen people with onset epilepsy and perimenopause, and when they get through, they no longer have it? Does that ever happen?
It goes different directions. So they can get worse, they can get better, or they can stay the same. And that's kind of the short answer.
To the long. But
It's not.
but that is not a pattern that necessarily that we see as like the huge one, because a lot of times it seems in those cases not even related to the menopause, if you will, rather related to some other issue there, sir.
So my niece has a brain malformation that causes her seizures. She's 2.5. Her last EEG was in 72 hours, and it showed that she no longer had the hips arrhythmia.
Okay, good.
So she's getting out of it. But she did go a month and a half without seizures, and then about a week ago she had a day where she had about 15 seizures in a day.
Yeah.
I asked the last presenter about Sable, like weaning off of Sable and going on to other medications. But you guys were talking a lot about implants in the devices. I don't know if there's a lot of research, but her brain malformation is called pachygyria. That will you think implants can be something that can be looked into, or?
It depends whether those malformations are easy to target or is it so widespread. If it's targeted, yeah, you could get away with doing some type of device approach. If it's widespread, then you're better off with a kind of a more medicinal thing that hits the larger system right there.
And at 2 years old, it may still be a little
Early.
for the devices because
Exactly.
as small as
Growth
they are.
issues and stuff.
So they may be kind of reserving that for a bit later. Again, don't want to make any assumptions.
Yes, ma'am.
You did have a question and you were waiting for a long time. Yeah.
So my son was born with hydrocephalus and a brain hemorrhage grade 4.
Yeah.
He had a ventricular access device placed in, but that was it. No, there hasn't been any buildup. He's been on 2 medicines, and then for the seizures, and then he had a EEG like 2 or 3 years ago, and they couldn't get a seizure on the results. And now because he's getting older, they want to change his medicine, but not do an EEG. But I don't know if that, like, because he keeps having the seizures, that's okay, or can I fight so that, can I stand and ask him to do the EEG?
So I would say that's a tough question because it's very specific and it sounds like he has a very, long story. I always tell my patients, I like to say, like, we want to hear the questions that, the patients and family members have to make the right decision. So I think it's always correct to ask, if you have a question, ask the question, right?
Yeah.
And I think the question should be something like, would an EEG help make decisions on what we're going to do for the medicine, right? And so kind of asking it in that way might be a little bit of a better, instead of saying, I want an EEG, well, what are you going to do with that information, right? And so it's not wrong to ask the question, right? I think if you feel like an EEG would be helpful, well then, yeah, you should say that, right? But from the doctor's side, I would say, is that going to be something that's going to help them make decisions for your son, right? And that's really where it comes
Well,
from.
thank you.
That's really
We are being given.
yeah, no, thank you.
Thank you so much, everyone, for staying with us.